Dr. Kelly invited me to give this presentation tonight, and I said no. I said, you really don't want me to do this? He said, yeah, I really do. And I said, well, I'll give you 2 weeks to think about it. Well, 2 weeks later, he called me up, and he says, I still want you to do it. And I said, but you know, I'm going to say what I really think. And he said, no, this group really wants to hear that. And I said, all right, I'll tell you what I really think. You know, I'm not a very politically correct person, and I certainly don't present with the impassionate style of a real professional, so please excuse me. But, you know, I am a real doctor, and I have been practicing for a long time. And sometimes I describe myself as the luckiest doctor in the world, and the reason is because my patients get well. You know, it wasn't always that way. I want you to know how I started. Just some of you know this story, but bear with me because some of you don't. I started out in Hawaii back in 1972. That's where Mary and I'd like to introduce Mary, my wife. Mary, would you just stand up? Yeah. Mary and I have been together since 1971. Well, we moved to Hawaii in 1972. I did my internship in Hawaii, so I can't be all that bad, right? And after the internship, we went to the Big Island of Hawaii, where I practiced as a plantation doctor, and that's where I learned everything I know today. I learned about diet and lifestyle. I learned about how lousy medicine is in terms of most of the treatments. You know, when I started out as a doctor there in 1972, I went in with the same attitude that you as professionals went into medicine with, is you wanted to help people. I know you did. I mean, those of you who are doctors, those of you who are nurses, or whatever you're in, you did it to help people. That's what medicine's all about. And I went out with that sincere intention to help people, and what happened is I failed. And I took it personally. My patients did not get well. You know, I passed out as many drugs as I possibly could, and they did not get well. And I thought it was because I was a lousy doctor. So I learned that during my 3 years as a plantation doctor. The other thing I learned is that illness was not inevitable, because I was taking care of first, second, third, and fourth generation Filipinos, Japanese, Chinese, and Koreans. And my first generation patients were always trim, hardworking, usually lived into their 80s and 90s, never had high blood pressure, prostate cancer, breast cancer, heart disease, or colon cancer. Never. And they lived on a diet of rice and vegetables that they learned back in their native land. Now they moved to the Big Island of Hawaii, and the kids, they learned a little bit more about rich food. And they became a little fatter and sicker, and then the grandkids, they learned the whole American diet, and they got really fat and sick. So it was right there before my eyes. I couldn't deny it. And then I went to become an internist. I quit my job as a plantation doctor, as a general practitioner, to become an internist because I wanted to become a doctor that could help people, and I wasn't helping people. I wasn't helping people. And so Mary and I moved back to Oahu, and I attended the University of Hawaii Medical Residency Program, and I became eventually a board-certified internist. In that process of learning to be an internist, I discovered lifestyle medicine. That was between 1976 and 1978. And since then, that's what I've been practicing, is lifestyle medicine. And it's not just about, you know, I can't just talk to you about how good lifestyle medicine is. I've got to talk to you about how bad traditional medicine is, and I'm really sorry. But, you know, until you really put what we're doing in perspective, then you can't reach out and grab a hold of what's right. And so that's what this presentation is going to be about, a little of both. I want to talk to you about the history of lifestyle medicine, at least as far as my life is concerned. One of the first exposures that I got to lifestyle medicine was from the writings of Daniel 2,600 years ago, and most of you are familiar with this particular passage out of Daniel. It's about how his men were sick because they were eating the rich food, and he asked the gatekeeper, the overseer, if they could do an experiment. Right, it was not a double-blind, placebo-controlled experiment, but it was an experiment that has lasted the test of time. It's still talked about and still written about. He put his men who were sick because they were eating from the king's table on vegetables and water, and then he reassessed them in 10 days and found that they were healthier than those men who continued to eat the royal food. And we should treat our servants based on what we see, shouldn't we? You know, that was the message 2,600 years ago, and it's just as true today as it was back then. People are sick because they're eating from the king's table. It's just that everybody happens to be eating from Dairy Queen and Burger King and Imperial Margarine. And let me tell you about some of the people that have been important to me. I didn't meet this man, but as far as I'm concerned, he's the one that really set lifestyle medicine into motion for modern times. He's Russell Henry Chittenden. He was the head of biochemistry at Yale University for 30 years. He is the father of biochemistry. And he was practicing his university medicine, and he was disturbed by an observation, and that is that the current scientists of the day, like Carl Voigt and Charles Atwater, and the real big deals in those times, they were recommending that people eat high-protein diets. And where they were recommending diet intakes of protein of 135 to 185 grams a day. And they were doing that based on an observation. It was an observation really which dictates bigotry. What they did is these experts in those days, they looked at the population around them, and they made an assumption. And that assumption is that people who could afford to eat almost anything would make the right choices. In other words, if you weren't wealthy, in other words, you were poor, and you could only eat fruits and vegetables, that's why you did. But if you had a little bit of money, like soldiers and workers, people who had a little money and had choice, they could buy meat and so on, then innately people would make the right choice, he assumed. And so he looked at what soldiers and workers ate and found out they ate between 135 and 185 grams of protein a day. And that was the recommendation given in the 1850s, and a recommendation that is still taught today, and is not based on a speck of science, just on that bigoted observation. Well, Russell Henry Chittenden, he said that this may not be right. He said, because I've observed things. I've seen that people in Central America and India and Asia, they live on a third that much protein. They seem to do well. And he says, I know vegetarians too. I know vegetarians in the United States and in Europe. And they do just fine on about a third as much protein. So he decided to challenge that concept with a bit of science, too. The first subject he started out with was himself. Because, of course, he was frightened that he might hurt somebody with this low-protein diet, right? So he cut his protein intake from, say, 150 grams a day to around 40 grams a day. And some interesting things happened to him. His daily sick feelings went away. His arthritic knees went away. He lost about 30 pounds. And he was really impressed. Not only did he not die, but he thrived. And so what he did next is he took 5 of his Yale faculty. Now, he didn't want to rush this experiment because, after all, the more physical demand, the more protein, obviously, you need. So he took sedentary people, 5 Yale faculty. And he put them on a similar diet, and they got similar results. They lost weight. Their aches and pains went away. And so next he took 13 members of the Army Corps of Engineers, and these are people who were physically active. They were out in the field, they were working, plus they vigorously exercised 1 day a week, and he put them on the diet, and the response was the same. They got healthier and thinner. And then the ultimate challenge was 8 Yale athletes, Olympic-type athletes. He put them on the diet, and they improved their performance by 35%. Now, that was over 100 years ago. And he did the experiments available at the time, careful dietary histories, urinalysis. And every single bit of scientific research done since then proves him right. Yet, still we teach high-protein diets to people. Walter Kepner, he made a big impression on me. Many of you know about the rice diet. He was one of the pioneers. He's one of the people whose shoulders I stand upon. Walter Kepner came to Duke University in 1939 and introduced the rice diet, a diet of rice and fruit and vegetables. And he did miraculous things to people back then. He took people with failing kidneys and stopped the progression of their kidney failure. People with enlarged hearts, half of the hearts went down to normal size. Half the EKG changes reversed to normal. He took care of people with severe hypertension, severe in our minds. It was common to him. And he made about 60% of them normotensive back in those days. And the rice diet is best known for its ability to cause people to lose weight, tremendous amounts of weight. Roy Swank, who I'm going to talk about on Friday morning. He's one of my heroes. I know Dr. Swank personally. I've known him for almost 20 years. He said something interesting. He said, gluttony and chronic degenerative diseases have been linked in the minds of both laymen and scientists for many years. He wrote that when I was 12 years old. He said, the saying, to dig your grave with your teeth, probably has its origins in antiquity, but in the prosperous areas of the Western world during the past few decades, the maxim has taken on real and tragic meaning. What was that? Well, that was 40 years ago. And what are things like today? Much worse, but he knew all the things that you know and I know. He knew those things back in 1950. And nothing seems to have happened. I'll tell you more about Dr. Swank on Friday. I know most of you know this man. This is the fiber man, Dennis Burkitt. He's the guy actually that changed my whole life. Mary and I were living in Grand Rapids, Michigan. He went to Battle Creek to talk to the Kellogg Company to try and get them to put more fiber in their food. He lectured at my hospital in Grand Rapids, Michigan. This is when Mary and I were first married back in 1972. It changed my life. You see, all the medical conferences I went to before then were dismal. They were depressing because all they talked about was the signs and symptoms of disease. They never talked about what caused it. Oh yeah, genetics and viruses, sure. But what could I do about that as just a lowly doctor? I couldn't cure those things. And finally, somebody walked into the lunchroom, a presentation, by the way, that was not put on by the drug companies. He walked into the lunchroom and he told us about his experiences. He was for 18 years the government surgeon of Uganda. After his training in Edinburgh, Scotland, he and a couple of his buddies, they moved to Uganda and started practicing. And lo and behold, they didn't find any of the diseases that they learned about in Edinburgh, Scotland to treat. They had, in 18 years, he saw no obesity, no constipation, no diverticulosis, no deep vein thrombosis, no pulmonary embolus. He saw one heart attack, he told me during that meeting, and that was a man who was a judge who trained in London and then went back to Uganda and had a heart attack. And he saw one case of gallbladder disease in 18 years. So, from that moment, I knew that these things were not inevitable, and then he made the link to diet. And of course, you all know that a high fiber diet is a plant food-based diet because fiber is only present in plants. Dennis Burkitt, he made a statement and showed a slide that I'm sure if you ever heard this man or read of his work, it stands in your mind, and that is America is a constipated nation. If you pass small stools, you have large hospitals. And Nathan Pritikin, now there's a man that made a big impression on me. He wasn't a doctor. But when I was first getting started in this diet and lifestyle business of mine, that's yours now too, I was quite frightened to learn the things that I knew and to think that maybe there was a cause to the problems that I was treating in my patients, and maybe there was a very valuable treatment. And I heard Nathan Pritikin talk, and it made me realize that it wasn't me that was having some kind of dream or hallucination, that these things really were true, because he said it so clearly. It was one of his statements is, I think it's ironic that the health agencies responsible for protecting our health are in effect destroying our health and shortening our lives. 1.5 million people are dying each year prematurely because their food supply is poisoned with excess fat and cholesterol. And he, along with Roy Swank and Walter Kepner and Russell Henry Chittenden, knew that you could not only prevent the common diseases that we have today, but you could also cure them with dietary and lifestyle change. And the last person I want to mention is somebody current. That's Dean Ornish. People always have a lot of opinions about Dean. He and I have known each other for at least 25 years. And he's one of the pioneers. He's made a huge difference. He said, I don't understand why asking people to eat a well-balanced vegetarian diet is considered drastic, while it is medically conservative to cut people open and put them on cholesterol-lowering drugs for the rest of their lives. Okay. So, we could go on. I mean, I could give you an hour-and-a-half presentation about people all the way from Socrates on that have discovered something very simple that all of you know in this room, I assume, and that is that the diseases that people have in this country are primarily due to their diet and lifestyle. That's the cause, and most of you know that you can change that. You can cure these people by dietary and lifestyle changes. So my question is if this has been known so long, why isn't it the common practice of medicine? When my patients, as I'm sure when some of you, they learn about the effectiveness of this, particularly going through our clinic, they just learn what powerful medicine is. They got off all their drugs. They get their life back. They ask, why didn't somebody else tell me this? Why have I suffered so much and nobody tells me this? Why is not diet and lifestyle medicine the norm? Why is it the exception? Why are we considered radical, unorthodox? Oh, I could go on with terms, too, for another hour, couldn't Well, the main problem is it's low profit. If we could change the profitability of lifestyle medicine, it would change overnight. But there's also the excuse that it takes some patient efforts. But of course, that's taught to us, isn't it? Yeah, we're taught that patients aren't very smart, right? And they're not going to do this. You know, I mean, that's what I was taught when I was in medical school. I was taught that patients are barely smart enough to sign the check at the end of the office visit and take our drugs. They're stupid and disinterested. And that's part of the education that goes on still today. I believe that patients are very willing, if we give them half a chance, to make these kinds of changes. I see it every day in my practice, and they're very grateful. It's not high tech. I had an experience one time. I read an article by Dr. Panish. I read an article by Dr. Panish about how you cure rheumatoid arthritis in the Annals of Internal Medicine. And so I was doing a radio show at that time, and I wanted him as a guest on my radio show, and so I tracked him down. He was at University of Florida in Gainesville originally. That's where I looked for him. He wasn't there anymore. He was at a big university on the East Coast. He'd become head of the Department of Internal Medicine. I called him up, and I was going to invite him to be a guest on my radio show. And I started out the conversation, well, Dr. Panish, I'm just so excited to talk to you. I mean, here you are, a man who's really stood up and said you can cure rheumatoid arthritis with diet. Published it in the Annals of Internal Medicine. And he says, wait a minute, I don't want to talk about that. I said, what do you mean you don't want to talk about it? He says, I don't do that anymore. I said, well, what do you do? He says, well, you know, I'm here at this big university. He says, you know, real doctors, they don't talk about diet and disease. I said, well, what do real doctors talk about? He says, well, you know, things like genetics and viruses and biochemistry and things like that. See, it's not sexy. I mean, you know, the person I saw at the front desk could teach you about diet and lifestyle. You don't have to be a dietitian or a doctor. I mean, anybody can teach you. I mean, it's not really sexy, is it? So it's not very popular. And then, of course, when you give a patient control, then you as a doctor lose control. And this is an ego-centered business, isn't it? Yeah, it is an ego-centered business. That's why we have operating theaters. Okay, so let's get down to the treatment of disease. I'd give us a report card, us medical doctors a report card. I'd give us an A for treating acute illnesses, and I'd give us, at best, a D- for treating chronic illnesses. So we've made, and I want to give credit where credit is due, we've made great contributions in terms of people's health in several areas, such as sanitation, antibiotics, of course, are really wonderful, trauma care, and immunizations. They've made a huge difference in the welfare of people throughout the world. So let's not lose sight of that fact. But these are acute illnesses that we're dealing with primarily. When it comes to chronic illness, 7 of the leading causes of death are due to chronic illness. They're the diseases you see up there, like heart disease and cancer and strokes and lung disease and diabetes and liver disease and atherosclerosis. And it represents 3/4 of the healthcare dollars spent in this country is spent on chronic illness. The treatment of chronic disease with drugs, with medications, can't possibly work. I mean, just the fact that it's called chronic and continues to be called chronic is an admission of failure, is it not? I think so. Americans are sick. They're sicker than ever, and most Americans over the age of 55 have at least one risk factor for diseases. For example, 1/3 have elevated cholesterol, most are inactive, 1/3 have high blood pressure, more than 30% are obese, more than 65% are overweight, and 10% are diabetic. I mean, those are the facts, and we treat those patients. We treat them primarily with medications, and what we treat, of course, is not the patient, not the disease, but we treat the risk factors, the signs and symptoms of disease. I want to introduce you to a term that you may have heard. I hope you hear it again and again this weekend. It's called disease mongering. A monger is a derogatory term for a dealer, maybe a used car dealer. And Dr. Ray Monahan, he defines disease mongering. It is selling of sickness that widens the boundaries of illness and grows the markets for those who sell and deliver treatments. It is exemplified most explicitly by the many pharmaceutical industry-funded disease awareness campaigns. Disease mongering turns healthy people into patients. The most common way we disease monger is to treat risk factors, not diseases. In fact, it's not just risk factors we're treating anymore. We're treating risk factors for risk factors. We're treating prehypertension and prediabetes and so on. And so that's what we treat as risk factors. I've been in practice nearly 40 years. Now, you challenge me if you can along the way. I'm happy to hear what you have to say. But I've been in practice for 40 years, and I have never seen a patient die of high cholesterol. I have never seen a patient die of high blood pressure, and I have never seen a patient die of high blood sugar, ever. But that's where we spend our efforts, is in lowering these risk factors. Now, we have medications. They do work. They work well. For example, we have statins and GI absorption blockers for cholesterol, and they lower those numbers. And we have various blockers and inhibitors for blood pressure, and they certainly do lower the blood pressure. And we have insulin enhancers to treat blood sugar, no question about it. But what's the results? What's the real results of this? We talked about antibiotics, anti-infective agents. They cure disease, right? They get in there and deal with that bacteria, that parasite, and they inhibit it so that we win the war. We tip the balance, and they really work, and they're phenomenal agents. Well, this is the physician's desk reference, and it advertises anti-infective agents over here, but it also advertises anti-diabetic agents. All right, some of you are doctors here. You've been in practice maybe as long as I have, maybe longer. How many of you have cured a patient of diabetes with anti-diabetic agents? Excuse me? Then why do you use them? How about antihypertensive agents? You ever cure a case of high blood pressure? I don't think so. These people who have these risk factors, they die of real diseases, don't they? I mean, they really are sick. Unfortunately, we don't treat the underlying sicknesses that kill them. And we see tragedies in people's lives. 1.2 million people have heart attacks every year, 700,000 have strokes. Now, what would happen if we would, instead of dealing with the risk factors, which we treat very effectively with drugs, we instead dealt with the underlying diseases? We might have to do something drastic, like change people's diets, or make them exercise, or cause them to quit smoking. I mean, but the problem is how do we charge for that? How do you make a living doing that? You know, that is really the challenge facing the people in this group, is how do you make a living doing what we do? That's the problem, is we can't figure that out. That's not true entirely. Okay, lifestyle medicine is what it's all about. It's correcting the cause through lifestyle medicine, and what we're doing basically, and I think most people in this room, I hope there aren't any Atkins advocates, most of you understand that it is a plant food-based diet, it's moderate exercise, and it's clean habits that really work. Let me give you an example of disease mongering, just so we all get up to speed on this and see how it works. The treatment of hypertension I'd like to use. The endpoints for treating high blood pressure, how do we succeed? Well, certainly blood pressure lowering medications, they lower blood pressure, right? Definitely no question about it. In fact, when you read the scientific studies on high blood pressure treatment, what do you find? Yes, drug A lowers blood pressure as well as drug B. But do they reduce the risk of dying of heart disease? No. They do not. Do they reduce the risk of stroke? A little bit. Do they have side effects and complications? Okay. We are taught by the provocatively dressed drug representatives. I'm being kind. And by the drug companies that high blood pressure medicine is very effective. It cuts the risk of stroke in half. And you think there as a practitioner, which I assume a good share of you are, is I would be foolish if I did not treat my patients with high blood pressure pills. Because treating with high blood pressure pills cuts the risk of stroke nearly in half. Well, if you look at the scientific research, this is what you find. The risk of stroke for 5 years is what we're looking at in people who have mild hypertension between 90 to 110 millimeters of mercury. If you don't treat them, they have 15 chances of having a stroke out of every 1,000 people left untreated. But if you treat them, their risk is now 9 chances out of every 1,000 patients. So what do we have here? We have a risk reduction over 5 years. That's 15 minus 9, which is 6, divided by 15, or we have a relative risk reduction of 40%. That's a relative risk reduction, but that's not the way we should look at things, is it? The risk of stroke for 5 years in terms of absolute reduction is 6 strokes per 1,000 people over 5 years. That's 1 less stroke per year by treating 1,000 people with medication. Looks a little bit differently, doesn't it? So what we do is we talk in terms of relative versus absolute risk reduction, which makes no sense at all. It makes a profitable sense, but no sense in terms of the welfare of our patients. The other thing that disease mongering does is it expands the definition of sickness. Now, when Walter Kepner was taking care of high blood pressure patients, his blood pressure patients came in with blood pressures of like 200 over 140. And by the way, he got 60% of them down to normal blood pressures. When I started in medicine, high blood pressure, it was called mild high blood pressure, was 160 over 100. And soon it became 140 over 90, and then there was a report, actually the first report came out about 18 years ago, but another one came out a couple of years ago that said if your blood pressure was 120 over 80 or greater, you had twice the risk of dying of heart disease. Made national headlines. I'm sure the PR people, the spin doctors of the drug companies made sure everybody learned about that. Now, that is true. If your blood pressure is elevated, it is an indication that you have higher risk of having diseases associated with a Western diet. It's a sign. It's a sign that says you're sick. But does treating signs necessarily solve the problem? Well, the drug company thinks that we ought to do that, even though the results of treatment don't show those benefits. And so we have doctors out there treating patients with blood pressures of 120 over 80 or higher, or maybe 110 over 70 or higher. Remember, that's prehypertension. And so you expand the market greatly by expanding the definition of sickness. Now, this is the guideline that I use, and the one I would encourage you to use. It's from the British literature. It's the most current guideline on treating high blood pressure. And this is why I don't feel uncomfortable at all taking patients off blood pressure-lowering medications. This is why I don't feel uncomfortable having my patients' blood pressures of 140 over 90 or 150 over 95 without medication. It's because of the British guidelines. The British guidelines has looked carefully at the scientific literature and made some profound statements that ought to dictate our practice. In these guidelines, there's summary points say that all people with high blood pressure, borderline or high normal blood pressure, should be advised on lifestyle modifications. Now, how many doctors do you think do that? I mean, do you think a patient goes into a doctor's office and when the blood pressure is detected, the first thing the doctor does is says you're going to take a 10-week diet and lifestyle course before I put you on drugs? Do you think that ever happens? Or do you think maybe more likely what happens is when the patient comes into the doctor's office, the first reading of elevated blood pressure dictates a lifelong treatment for high blood pressure? Do you think that's possible? I think so. And then they go on and they say you should initiate drug therapy if sustained. That doesn't mean like 15 minutes. That means like months. If sustained greater than 160 systolic and 100 or greater diastolic. That's what the British guidelines say. Now, if you feel uncomfortable about not initiating high blood pressure therapy, for which you know is less than mild hypertension, or you feel uncomfortable about taking people off of blood pressure medications, just use the British guidelines. It's the most current recommendations out there, and I believe much less biased because I believe the British literature is much less influenced than the US literature. Okay, disease mongering. Here's another way to do it. You exaggerate the goals of treatment. The goal, I tell you, I just cannot even think of any patient who's come in with other than the goal of having the blood pressure made normal with drugs. 110 over 70 or less, that's the goal. Well, that goal results in more death and disability, more heart attacks. And you probably are all aware of this. It's called the U or J-shaped phenomenon of mortality. What happens is when the diastolic is high, we're looking at diastolic numbers here. When it's high and if you treat, say it's 120, when you treat the blood pressure, the risk of heart attacks and death decreases until you hit a level of about 95 millimeters of mercury on diastolic. Certainly no lower than 85 millimeters of mercury, and then the risk of death increases. It's called the J or U phenomenon of mortality. It's been written about for over 30 years. And it makes a lot of sense, doesn't it? Here you have a patient whose blood vessel system is all clogged up. It's full of sludge from what they ate. Their arteries are in spasm. the heart and the body perceives there's problems. We're not delivering the nutrients to the tissues because of all this peripheral resistance. So what do we need to do, the body says to itself? It says, well, we need to increase the pressure in the system so the pressure goes up. And so what do we do as agents of medical care, agents of the pharmaceutical industry, is we poison the system at various levels. We poison the heart with beta blockers. We poison the arteries with calcium channel blockers. We poison the kidneys with diuretics. And the blood pressure comes down, as expected. But what happens to all that effort the body is making to deliver nutrients to the tissues? Yeah, what happens is that effort is stopped. And the consequence is you decrease perfusion pressures to the tissues and the patient dies. Well, at least he died with a normal blood pressure, right? Okay, so diet and lifestyle. What does diet and lifestyle do? Diet and lifestyle reduces risk factors for strokes, like blood pressure and cholesterol and obesity, and it also reduces strokes. A review of the literature presented in 2006 shows a diet low in sodium, high in potassium, rich in fruits and vegetables, whole grain, cereal fiber, and fatty fish. I would make a contention with that one, but we'll do that in another lecture. Will likely reduce the incidence of strokes. All right, let's talk about anti-diabetic patient medications. Oh, excuse me, that should be anti-diabetic medications. The endpoints for type 2 diabetes is to lower blood pressure, blood sugar. You know, I don't know about you folks, any of you who are in medicine, but I was always frustrated. Even when I was in training, and I am today whenever I see it happen, to treat a type 2 diabetic, I've never been able to do it successfully. No, I mean, if you call successful achieving a stable low blood sugar, I've never been able to do it. And I've never seen anybody else do it, but maybe you can do it. You know, you take the patient, you put them on a whole bunch of pills and a whole bunch of insulin. Their blood sugar one day is 285, the next day it's 55, the next day it's 170, the next day it's 210. You know, it's all over the place. I don't know, maybe you guys are better doctors than I am. I can't do it. Do you reduce the chance of getting a heart attack and dying of a heart attack? The answer is no. Do you cause weight gain? Yes. And do you cause complications? No question about it. There is a statement that appears in the PDR. It started appearing in 1972. It appears also in 2006 and every year in between. It's about the UDGP study that was done and reported. The UDGP, do you ever see this paragraph, heavy black print? Well, just pick out your PDR and take a look. There's only 2 paragraphs of heavy black print that appear under oral diabetic medications, particularly the sulfonylureas. Has appeared there since 1972. Is in your 2006 edition. What it says is special warning on increased risk of cardiovascular mortality. It says the UGDP study found that patients treated for 5 to 8 years with a fixed dose of a sulfonylurea increased the risk of dying of heart disease by 2.5 times. Now, how could anybody prescribe a medication with that kind of warning on it when your goal is to keep these people from dying of heart disease, since you already know they don't die of high blood sugar? How could anybody prescribe this? You know, if you're as old as I am, back in 1972 when this warning came out, sulfonylureas disappeared. It stopped using them. And of course, the drug companies with their spin doctors and their drug salespeople and their ability to manipulate the literature have gotten to the point where these drugs, which are extremely highly profitable, are back into every doctor's office. But it hasn't changed this warning. And of course, when you take anti-diabetic pills, you increase insulin levels, and high insulin levels do what? They drive fat into fat cells, and so these people gain about 20 pounds when you initiate therapy, which is kind of an interesting thing, isn't it? Here's the scenario that I remember, and the one that patients tell me quite often is they go to the doctor, they have diabetes. Doctor says, you got diabetes, you know, you're fat, you need to lose weight. I'm going to put you on these diabetic pills. Patient says, great. Comes back the next month, patient gets up on the scale, the doctor looks at the patient and says, hey, I told you to lose weight. Look at you, you're even fatter. And now that you're fatter, your blood sugar's higher, now I got to give you more pills that make you gain weight. It goes on and on and on, doesn't it? That's why one of the first things I do when I take care of a type 2 diabetic is I take them off all their diabetic pills, and I take them off most of their insulin or all their insulin. A type 2 diabetic, of course, not a type 1. Because you got to break that cycle. You got to get them to start to lose weight. That's what you have to do. That's what you've been telling. That's what every doctor tells every diabetic, type 2 diabetic, is lose the weight, and then they give them pills that make them fat. Okay, as far as the heart disease, I just want to go through 3 major studies with you. You can look these up if you want. The record is clear. The Diabetes Control and Complication Study trial on type 1 diabetics, the largest study ever done, 6.5 years of intensive insulin therapy for type 1 diabetics. The results compared to people treated less aggressively is you increase the risk factors of dying of heart disease. They got fatter, higher cholesterol, high bad cholesterol, high triglycerides, and higher blood pressure in those aggressively treated. How about the Veterans Affairs Cooperative Study in glycemic control and complications of non-insulin dependent diabetes? Type 2 diabetics with a history of heart attack were treated. Those treated with insulin and diabetic medications had an increased risk of death. And how about the Trea Study, the very large European study, diabetic patients with a history of heart attacks treated with diabetic pills and or insulin? Results, almost twice the death rate as those treated with diet alone, and diabetics treated without medication, in other words, diet alone, had the same death rate as people without diabetes. Are we supposed to feel good about treating diabetics with diabetic pills? I know of no evidence that says otherwise. Maybe you could enlighten me. Okay, how about diet and lifestyle? And I have to admit, you know, there's not a lot of research on diet and lifestyle, but you know why. There's not the money. I mean, you don't have billions of dollars like the drug companies do, so it's hard to get this kind of research done. But what does exist in type 2 diabetes is that you can reduce the risk factors clearly, in other words, obesity, and if you change them to a vegetarian diet, insulin resistance decreases or disappears. Also, it has been shown in studies as far back as Shirley Sweeney in 1927, Rabinovich in 1939, and most recently Neil Bernard in 1999, that you can cure these people of type 2 diabetes simply by changing their diet. Well, why not? Why wouldn't you be able to? I mean, after all, everybody, I don't think you could find a doctor any place in any society, be it Europe, Asia, or the United States, that would tell you anything but a type 2 diabetic is a type 2 diabetic because they ate the greasy American diet and got fat. Does anybody have another explanation for it? I don't know. Well, what happened if you stopped doing that to them and they got healthy and thin? Would their type 2 diabetes go away? I think so. I mean, that's what I see. And so Neil Bernard and his group, the use of a low-fat vegetarian diet in patients with type 2 diabetes was associated with a significant reduction in fasting glucose concentration and body weight in the absence of recommendations for exercise. That's pretty cool. Oh, I want to tell you, I used to work at St. Helena Hospital. Some of you know that, yes? I was there for 16 years, and it was a very good experience. I had very many fond memories of it, but there were reasons that I left, and many reasons. You know, it just is a lot of things that kind of build up over time. But one of the reasons that caused me to leave, I'd like to share with you one of the experiences I had that was kind of interesting. I don't go to noontime conferences. I stopped going many years ago. I don't know whether you still go. I guess the free lunch is worthwhile. It's hard to shell over $2.50, right, for a lunch. I don't go. Because you know what? It's an insult to my intelligence to have a drug rep sit in detail lecture to me. But I was at the hospital a few years back, and I saw a title of a lecture. It was Diabetes is Caused by Fat, Not Sugar. Oh, boy, somebody's got it. We got to go listen to this. So I gathered all my staff together, and we went down to the lunchroom. And we walked in, and my first clue that there was a problem was the Pfizer representative was sitting in the back of the room. And then the speaker walked in, and he was obese with acne, greasy skin, and a ponytail. So I thought this is going to be a long hour, but you know, who knows? It could be, who knows? I get surprised all the time. Well, anyway, I sat down and listened for a whole hour to the presentation. And listen to the man tell me how to properly take care of a diabetic. And I counted. I finally got to listing all the drugs he said I needed to use to care for a diabetic. I needed several types of oral medication, maybe some insulin. I needed to put them on a cholesterol-lowering drug. I needed to put them on some calcium channel blockers, some ACE inhibitors. Oh, always got to be on ACE inhibitors to protect those kidneys. And it went on and on and on. And finally, I had a list of at least 20 drugs that a well-treated diabetic should be on. And he made it sound really good because it gave it a sexy term. He called it polypharmacology. I could just hear all the doctors going, "Ooh, I'm practicing pharmacology." Oh, boy. Anyway, I waited till the end of the presentation, and I raised my hand. I said, "Hey, doctor, The title of your lecture is Diet is Caused by Fat, Not Sugar. I said, did I miss something? You didn't mention diet once in the entire hour. He says, I got you here, didn't I? I said, yeah, you got me here. I said, but you know, a lot of the drugs you mentioned, I said, they kill diabetics, like sulfonylureas and calcium channel blockers. And, you know, about that time, one of my mentors, and somebody you probably know, somebody who was the head of my health center at that time, John Hodgkin, jumped up and apologized for my behavior. In a very politically correct way, may I mention. Yes, he was very good about it. Said, this is Dr. McDougall. He writes health food books. You know, you have to excuse him. So anyway, I made a few other comments. And then we're walking out of the room together, John and I are. He's a good friend, still is a good friend. And we're walking out of the room together. Some of you know him. He's a great doctor. And I looked over at John and I said, you know, our colleagues don't believe, really, they don't believe that's the way you treat a diabetic, do they? He says, yes, we do. That moment I decided I did not want to be associated with my colleagues anymore, because that's not the way you take care of a diabetic or any patient. I mean, think about the patients you take care of. They're not on one drug. They're on a bag full of drugs. They're on something for blood pressure like Norvasc, calcium channel blockers, which are very deadly, increase the risk of dying of heart disease, cancer, breast cancer, suicide, and bleeding. Blood sugar medications, cholesterol-lowering medications, something for uric acids like xyloprim. Homocysteine, that's a good one. Folic acid, we just saw 2 large reports that show that it increased the risk of heart disease and death by about 30%. Triglycerides like Lopid, you no longer put patients on aspirin that you can buy 50 for a penny, do you? No, you got to put them on $4 aspirin called Plavix, which increases the risk of stroke and other breathing problems. But believe me, they've paid for studies to make sure that we do those things. Something for your body fat like Orlistat, headaches like Darvocet, body aches, indigestion, you give them something from an antacid. They're all on antacids, right? And then they're constipated, put them on Miralax and something for diarrhea, and they stink so bad from all the meat they eat, you got to put them on deodorants. I forgot one drug, and I'm sorry, I forgot to mention. If they keep complaining and keep coming back, because you know you're supposed to cure them as a doctor, when they complain so much you're just sick and tired of listening to them, what do? Put them on an antidepressant, right? Yeah, they're always on antidepressants. Okay. I want to introduce you to a patient. This is somebody I've known for a while. This man, he knew he had some problems, so he decided to go to the doctor, and he was diagnosed with high blood pressure, type 2 diabetes, hypercholesterolemia, hypertriglyceridemia, gout, mild kidney failure, overweight, mild osteoarthritis, constipation, depression. I'm not exaggerating. This is true. I mean, do you know any patients like that? Of course you do. So he went to the doctor, and he went to the doctor for 2 years and paid, you know, the monthly office visit, paid thousands of dollars for medications, and followed the advice strictly for 2 years. And what I want to show you now is a picture of him 2 years later. He still has high blood pressure, type 2 diabetes, hypercholesterolemia, hypertriglyceridemia, gout, mild kidney failure, overweight, arthritis, constipation, depression. Okay, now here's the trick question. What do you see different about this man? What miraculous change do you see that's taken place in 2 years? Nothing. He's still just as fat and sick as he was 2 years before. Now, I ask you about your patients, your friends, your relatives, your patients. You tell me what happened when they underwent good medical care. Nothing. They're still fat and sick, and now they're carrying around a bag full of drugs. And that is it. And if you are a doctor, you must believe you're doing some good because you cannot see it. Somebody want to challenge me? I tell you, John, you should have invited me. Okay, let's talk about some of the real serious problems going on in medicine. Let's talk about the treatment of heart disease with surgery. Can't possibly work. Can't work. Doesn't work. Studies show it doesn't work. We're talking about the angioplasty business, and they do 1 million of those a year in this country. We're talking about bypass, which they only do 400,000 a year in this country. Combined, it's a $100 billion a year business, and 80% of the hospital, your hospital's income comes from heart disease. If you have a cardiac business going on there, 80% of their income comes from heart disease. Now, there have been some studies to look at the benefits of surgery versus medical therapy. There have been 3 major studies done. They were all done before 1990. There'll be no further studies done. They've already looked at the situation, they've expressed the results, and it doesn't work. The vast majority of people, we're talking about 90% plus, survive no longer with surgical therapy than they do with medical therapy. You say, well, what about the exceptions? You know, the widowmaker, left main coronary artery disease. Well, the CAS study says they don't live any longer. And how about left main equivalent, when all vessels are blocked up? Well, CAS study says they don't live any longer with surgery than medical therapy. What's the CAS study say? That's the most recent one done. The CAS study says, doesn't matter what the anatomy looks like, doesn't matter if it's left main, doesn't matter how many vessels are diseased. What matters is what has happened to the left ventricle. You know, what they did is they played the game, and then they set the rules. They saw that those people with left ventricle damage, expressed by an ejection fraction of 50% or less, have an 18% increased survival over 10 years. And they brag about it. Now, the truth is, angioplasty, now bypass has been done since 1968, angioplasty has been done since 1978. There is not a single study that shows that angioplasty prolongs lives. Not a single study. They do 1 million a year, and they get away with it. Can't possibly work. A recent article, I encourage you to read it. You can find it online. If not, go to your library. It was July 18th, 2005, Business Week magazine. The title of the article is Heart Surgery Worth It? And it's a review of the treatment of heart surgery. It's a review that, by the way, John mentioned a book I wrote in 1985. It's basically the review I wrote in 1985 of heart surgery. It doesn't work. In fact, one of the key authors, the key people who was interviewed in this article, Dr. Hadler, who is a professor at the University of North Carolina, Chapel Hill, he says bypass surgery in particular, he says, should have been relegated to the archives 15 years ago. I'd say 20 years ago. Read it. Your patients should read it. I hand this out to my patients. It's a great review. It's well written, uncontested. It's the truth. Now, why can't bypass surgery and angioplasty work? It's because they don't treat the killing part of the disease. The killing part of the disease is not the large blockages. The killing part of the disease is the tiny little fat-filled plaques that are volatile and burst and cause a blood clot to form. That's why we call heart attacks coronary artery thrombosis, because essentially all of them are caused by this mechanism. It's the little tiny pimples. Little tiny pimples on the inside of the arteries that burst like a pimple on a teenager's face, and as a result of the products of injury that are released, the blood clots, and that's why you have the acute coronary syndrome. That's why. Bypass surgery doesn't treat those. Bypass surgery treats the big blockages, the ones that are full of scar tissue and calcium, the ones that may be causing chest pain, but they're solid as a rock. In fact, to add insult to injury, the day after bypass surgery of a heart attack, what do we do for the patient? We serve them the same foods that brought them there in the first place. Here you have this teaching moment. You know, the doctor walks in, and the patient looks at the doctor with frightened eyes and says, "Doctor, I need cardboard not to come back here. What should I do?" "I don't know, but you better eat that cheeseburger. You need the protein to heal your wound." In every coronary care unit, including the Adventist ones that I've been in, they serve them the same foods that brought them in the first place. Do you understand that? I don't. Oh, yeah, they starting them on statin drugs as soon as they had a heart attack. Of course, that doesn't work, but how about doing something really radical like feeding them a healthy diet from the moment they had a heart attack? Well, that might be novel. So you have a situation where what they're bypassing is non-lethal disease. What they're doing angioplasty on is non-lethal disease. It's not the part that kills. The part that kills is the little pimple next to the big plaque that pops and causes the blood to clot. So it really needs to be clear that that's the problem. And of course, when you go in there with your angioplasty catheter, what do? You blow up the balloon, you cut with a laser or a knife, and what do? You create products of injury. And the consequence is the blood clots. And so 40 to 50% of the people so treated, their artery completely closes down in 5 months. Of course, now we have stents, right? So now it's only 20% due to cell proliferation. And there are other problems with that, but enough said. Okay, this is a reversible disease. This is not concrete. This is not cement in a person's arteries. Cholesterol and fat, they go into the plaques. They create the inflammation. When you change your diet, what happens is you change the equation, so now more cholesterol and fat come out of the plaque. The surface tension is decreased. They're less likely to pop the pimple, burst the volatile plaque. You bathe the plaque with cleaner blood, healthier blood, so it stabilizes the membranes. The other thing you do as soon as you feed a healthy diet is you remove the strongest clotting factors people come in contact with, and that's animal fat. Animal fat makes the platelets very adhesive, makes the clotting factors very aggressive, particularly clotting factor 7. So you just set them up for a clot by feeding them the rich American diet. As soon as you change your diet, I'm talking about hours after you change their diet, they realize the benefits. The risk reduction is there. So, diet and lifestyle, they reduce the major risk factors for heart disease, like cholesterol and triglycerides, high blood pressure, obesity, insulin resistance. Going back to Dean Ornish, he says, according to the PET scans, 99% of the patients stopped or reversed the progression of coronary artery disease. When we understand that this is a diet and lifestyle disease, artery disease, we get to treat a whole bunch of problems. It's just not the heart arteries. There are all kinds of arteries, all different arteries over the body that are compromised by atherosclerosis. And the arteries, they either supply insufficient amounts of blood or they close down, and as a result, they cause common diseases. For example, you close the arteries to the eye and you get macular degeneration. You close the arteries to the ears and people go deaf, they get tinnitus and vertigo. You close the arteries to the brain, you get a stroke. To the heart, you get heart attacks. You close the arteries that feed the aorta, you know, the vasa vasorum, and the tissue strength of the aorta decreases and you have an aneurysm. You close the arteries to the bowel, you get bowel infarction. You close the arteries to the spine and you get back pain, you get degenerative disc disease. I mean, the clue to it should be degenerative. I mean, that's the clue to what causes it. It's degenerative. Degenerative disc disease. It's not like somebody picks up a Volkswagen or a piano and their disc ruptures. It's like they turn or take a step and the degenerative disc pops. It's a vascular problem. You close the arteries to the legs and they get intermittent claudication. You close them down really badly, you get gangrene. Now, a real motivator here is you close the arteries to the penis and you become impotent. Some people say that's worse than death. I wouldn't know. Okay, let's talk about cancer for a few minutes. You know, nobody wants to talk about cancer. That's just, I mean, you know, heart disease, high blood pressure. But cancer is kind of the sacred cow, isn't it? We're all afraid of the cancer doctors and the cancer patients. I'd like to talk about cancer for a couple of minutes. Prevention by screening and treatment of common cancers with medications, radiation, and or surgery cannot possibly work. If you understand the natural history, just like you understand or understood even before you met me, the natural history of coronary artery disease, you understand why it can't work. If you understand the natural history of cancer, you understand why present therapies and screening cannot work. It's impossible. Now, I have to qualify before I go on here that there are some real important exceptions. And that is when we find precancerous changes, that means before cancer, superficial changes, I believe we can make a difference when it comes to screening. For example, when we do Pap smears, and I do recommend Pap smears every 3 to 5 years up until the age of 50. Colon polyps, that's a precancerous lesion. I think if we take those out, we can reduce the risk of colon cancer. But interesting, my son is at Ohio State University in first year of medical school. He called me up very upset because he went to a lecture on preventing colon cancer. He says, Dad, in the whole lecture they didn't mention diet once. All they talked about was colonoscopies. But the title of the lecture was Prevention of Colon Cancer. I said, get used to it, kid. Leukoplakia in the mouth and skin changes. You can catch melanoma early enough? I believe so. But see, these are superficial changes prior to them turning into cancer. You can make a difference. And I also want to point out that we do have treatments for cancers that do work. And these are cancers like childhood cancers and testicular cancer and lymphomas and leukemias. We do have treatments that we should be very proud of. Okay, you have those qualifications firmly in mind for the rest of the discussion. John C. Baylor from the National Cancer Institute, he wrote a very important paper, a landmark paper, which made a lot of people upset in 1997 in the New England Journal of Medicine. He said, this is like what Richard Nixon said we were going to win the war on cancer by 2000. But anyway, he said the risk of dying from cancer has increased by 6% from 1970 to 1994. He said the war against cancer is far from over. Observed changes in mortality due to cancer primarily reflect changing incidence and early detection. The effect of new treatments for cancer on mortality have been largely disappointing. The most promising approach to control cancer is a national commitment to prevention, with a commitment rebalancing of the focus and funding of research, which of course hasn't happened. But here's a couple of my heroes. You know, I've had a chance to talk to you about a lot of people who had a big influence on me. Well, these two people have too. Charles Wright is one of the most famous epidemiologists in the world, and C. Barbara Mueller is the father of breast cancer surgery. I've known him for 30 years. And I had him on my television show. I have a TV show. It's called McDougall, MD. It still plays worldwide. But this was a show we did about 6 years ago. And I had them on the show, and we talked about a scientific paper that they published in The Lancet. It was the lead article in Lancet in 1995. And they looked at the various studies. There are actually 6 or 8, depending on how you divide them, studies of mammography, breast cancer screening. And they looked at those studies, and they said, since the benefit achieved is marginal, the harm caused is substantial, and the costs incurred are enormous, we suggest that public funding for breast cancer screening in any age group is not justifiable. Yeah, that's what they said. I mean, this is heresy, but that's what they said. And no one contested it in the letters to the editor. But I still recommended mammography, by the way, in 1995. I recommended it for women between the ages of 50 and 68. Not below 50 because it is notorious for being a failure, and after 68 because you don't live long enough if something was detected to show any benefits. But I still would tell a woman that, you know, you ought to get a mammogram. Or if she asked, you know, I told her there's some evidence, there's some benefit. And I took that stand until Lancet came out with an article in 2000, and then they came out with their final report in 2001. The Cochrane group is a group of scientists who, it's a Nordic group, who are known for their evaluations of drugs and treatments without bias and with thorough investigation. They're very famous. I'm sure most of you know who they are. The Cochrane Reviews. We'll be talking about them on Friday when I talk about drug treatment for multiple sclerosis. Anyway, the couple of researchers, when they wrote in Lancet in 2001, they said in 2000 we reported that there is no reliable evidence that screening for breast cancer reduces mortality. As we discuss here, a Cochrane review has now confirmed and strengthened our previous findings. The review also shows that breast cancer mortality is a misleading outcome measure. And finally, we use data supplemental to those in the Cochrane review to show that screening leads to more aggressive treatment. Yeah. Well, that made a lot of people mad. And how about breast self-examination? I mean, who could even think that breast self-examination would bother anybody? And it would be something you would avoid recommending. But the Canadian Task Force on Preventive Medicine, they looked at the issue in 2001. They said there are 2 randomized controlled trials, a quasi-randomized trial, a large cohort study, and several case-controlled trials. And they have failed to show benefit from regular performance of breast self-examination or breast self-examination education compared to no breast self-examination. In contrast, there is good evidence of harm from breast self-examination instruction, including significant increases in the number of physician visits for the evaluation of benign breast lesions and a significantly higher rate of benign breast biopsies. So what did they tell us to do for our patients? Is they told us not to recommend breast self-examination. They said, and it's in all age groups, but I'll just read one for you, is because there is fair evidence of no benefit and good evidence of harm, there is fair evidence to recommend that routine teaching of breast self-examination be excluded from periodic health examination of women in this age group, and so on and so on and so on. Can you imagine that? Okay. We went through the treatments and looked at the survival benefits from various treatments, you generally come down to these conclusions. For solid tumors, surgery provides no survival benefit. Radiation provides no survival benefit. Oh, you could tell me maybe in a couple of exceptions here, but the bulk of the literature shows this. Hormone manipulation shows some for breast and prostate cancer, and that's things like removing the ovaries, taking off the testicles, giving anti-estrogen treatments. And maybe even chemotherapy works by knocking out the ovaries. That's my guess. And chemotherapy, the benefits are little and the harms are substantial. Let me explain why this is true. Now, once you know the mechanism underlying cancer, it's all obvious why screening can't work and nor can treatment. Let's talk about the mechanism of cancer growth. And you can read about this. You want to read a 40-page report on this right here. It's on 40 pages, 15 pages. Anyway, cells live in a neighborly manner, and they're not allowed to divide anytime they want. If they divided anytime they want at their own free will, we'd become misshapen masses in a matter of days. So cells are allowed to divide under certain circumstances, like if there's a stimulus for growth from a brain signal or hormone signal, then we're allowed to grow. If a cell gets injured, like we get a laceration, then the cells next to that injury can proliferate, can grow, and repair the injury. That's fair. That's what's allowed to be done. And we have these regulatory mechanisms that make sure this works correctly and properly, so we stay in the form that we are. Well, cells get injured, and they get injured by things like radiation and products of cigarette smoke, combustion, and various toxins in our environment. And as a consequence of injury, when it's serious, most cells die. But sometimes cells die, or cells get injured, not bad enough to die, but bad enough to stop being neighborly. And then they start dividing at their own free will, and that's, of course, the transition from normal to cancer. And one cell always leads the way in the breast or the prostate. One cell always leads the way. So let's take that cell. The first cell begins, and the doubling time, on average, the doubling time is every 100 days for a solid tumor, be it breast, colon, prostate, or lung. It's every 100 days. So 100 days later, you have 2 cancer cells. 3.5 months later, you have 4. And now you have had a cancer for a year, and you've got 8 to 12 cells lurking in a breast that contains 100 billion cells per breast, and a prostate that contains 100 billion cells. Of course, obviously undetectable. Divisions continue. You go to 16, 32, 64. You've had cancer for a year, and you have less than 100 cells in your tumor mass. You couldn't possibly find it. At these early stages, if it's truly cancer, then it starts to metastasize, and the tissues it goes to, it has a similar doubling rate to the original tumor. And of course, it's the metastases that kill. It's not the original tumor. No one dies of breast cancer or prostate cancer. They die of metastases to the lungs, bone, brain, etc. Well, the divisions continue, and finally you reach a tumor mass after 6 years on average that contains 1 million cells. It's the size of a period on a paper, a lead tip. It's undetectable by any current means, yet it has been growing 6 years. It has amassed 1 million cells. If it is truly cancer, it is spread over 90% of the time, and probably 100% of the time. If it's truly cancer, there are lots of things that we treat that we tell the patients it's cancer, and it's really not cancer. Anyway, so the divisions continue, and finally you get to a detectable tumor mass. It's 1 billion cells in size. It's a centimeter, the size of an eraser of a pencil. At this size, the tumor now is able to increase the PSA level. Prostatic specific antigen increases only after the mass is a centimeter in size. In other words, it's been growing an average of 10 years, and it contains 1 billion cells. It's the size that you can feel on digital rectal examination or breast self-examination. You may pick up a tumor mass 6 to 2 years earlier on mammography, but the truth is because of the kinds of tumor masses that are picked up on mammography, the average length of doubling is about 14 years before you find them. 2/3 of the disease has occurred without the knowledge of the patient or the doctor. It has already expressed itself. In more crude terms, the cattle are already out of the barn before the door is closed. And that's the truth. And every oncologist and every doctor should know that. That's the natural history of this disease. So how in the world are you going to take and treat a disease that's already expressed itself with local treatments like surgery and radiation? It's impossible. That's why they don't survive any longer. It'd be nice if we had chemotherapy agents that worked. It really would be. But by and large, the chemotherapy agents are ineffective, and I gave you some exceptions, and they're very toxic. Of course, that's why chemotherapy is so popular, is because everybody realizes this natural history. And local therapy does not treat systemic disease. It can't possibly do it. It'll never work. It'll never work. But we continue to do it. You know, even after these kinds of realizations and even after the effort to change from more radical to more conservative therapy in terms of prostate cancer, in terms of breast cancer, you know, still these days 65% of women get mastectomies. And we've had laws of informed consent in 18 states as long ago as 30 years ago. And yet 65% of women get mastectomies. Oh, by the way, this doubling time is on average every 100 days, but some women double their tumors every 24 days. Some women double their tumors every 850 days. I believe you can change that doubling time with a change in diet. I did and published the first scientific study on the dietary treatment of breast cancer in about 1982. Since then, there have been about 20 studies published in our best medical journals on the dietary treatment of breast cancer and other cancers. And everything says you can slow that doubling time. And so our goal should be to slow the doubling time, so instead of a woman dying in 3 years, she dies in 12 years. Or maybe our goal should be to have all of our patients with prostate and breast cancer die of their disease when they're 95. We're certainly not accomplishing that with present methods. Okay, diet and lifestyle benefits. Well, we reduce major risk factors. Those risk factors for hormone-related cancers like breast cancer are obesity, IGF-1, insulin-like growth factor 1, cholesterol, estrogens, and prolactins. A study published in JAMA in 2005, a study on physical activity showed walking 3 to 5 hours a week, that's casual walking, reduced the absolute risk of death for women with breast cancer by 6% over 10 years. That's as good as any chemotherapy. And we had a big failure here, didn't we, a few months ago? We had the Women's Health Initiative randomized controlled dietary modification trial. It had national headlines. Everybody liked that trial because it taught them, it gave them a message of good news about their bad habits. Low-fat diets don't work. Isn't that what happened? I think so. I think that's what happened. That's why I got so much publicity, is you no longer have to follow a low-fat diet because the Women's Health Initiative randomized controlled dietary modification trial showed that a low-fat diet doesn't work. But of course, I'm sure all of you are familiar with this, is that the average weight loss was only 1 pound greater in those on the low-fat diet compared to those on the control group after 8 years. They didn't go on a low-fat diet. Now, Rowan Chablowski, who's here in Los Angeles, and Ernst Winder, who is head of the American Health Foundation, they were associates of mine many years ago, in a sense that I knew them. I had them on my radio show on a couple of occasions and on my television show. Every time I had them on the shows, I would say, why are you doing this? Why are you feeding these people a high-fat diet? Well, they said that they didn't believe that anybody would really truly follow a low-fat diet. And of course, I said, you're wrong. I said, when the day comes that you publish your studies, it'll be a failure. And of course, the day came just a couple of months ago, and they published the studies, and it was a failure. And as a result, it did terrible harm to the movement of a healthy diet and preventive medicine and lifestyle medicine. They didn't feed them a low-fat diet. They didn't follow a low-fat diet. But even though what they did, it's kind of interesting. On average, there was a 9.8% of the women on the low-fat diet had recurrences at 5 years compared to those on the standard diet, which was 12.4%. Again, results comparable to chemotherapy. So even with the little they did change, and as far as preventing breast cancer, 1 more serving of fruits and vegetables daily, which is what they accomplished, resulted in a 9% reduction in breast cancer observed in the low-fat group. So the little change they did make did show some results. But it's a shame because people who are contrary to a healthy diet, they use this as ammunition to show it doesn't work. Okay, so just to kind of summarize what we've talked about is to better currently recommended treatments, drug therapies, surgeries for heart disease, surgeries and various treatments for cancer, you don't have to do much. Lifestyle medicine has to do almost nothing, especially since what we recommend causes no harm and costs nothing. You see, I think that's the point of view that we have to take. If we're going to make a big college, if we're going to make a real difference in people's lives, we can't sit back and say we've got something as good as, we've got something better than. And they've spent billions of dollars proving that what they do does not work. The research is there, and you need to know it. Okay. Treatment of chronic diseases with diet and lifestyle medicine cannot possibly fail. Let's agree on a few things, you and I, okay? For just a minute, let's go through a few basic ideas here. I was at a restaurant Terry Shintani and John Westerdahl from Hawaii know this restaurant. It's John Dominus. We're at John Dominus, not eating the fish, looking at them. And we're sitting there at the table, Mary and I and our son, and this lady walks up with a camera. She says, I'd like to take your family's picture. It'll be $10. I said, no, thanks. I said, but see this family over here? I said, I'd like you to take their picture. And so she went over and took the picture, and she sold it to me for $10. Now, these ladies, they're speaking Japanese. They're ordering rice and vegetable dishes primarily, and they're obviously first and second generation Japanese ladies, older, healthy, young looking. And I got my picture for $10, and I said, oh, that was pretty cool. I wonder if I can do that again. So I said, you see that family over to my right? I said, go take their picture. So she came back, she sold it to me for $10. It's a true story. Can you tell the difference? These people are Japanese also. They're third and fourth generation. What do you think happened to these people? What do you think happened between the third and fourth generation? What happened to those people? Did they change their genes? I don't mean their genes. I mean their genes. Did they change their genetics? Did they catch a virus? Is that what happened? They caught a virus? Huh? What happened to them? They stopped eating rice and vegetables, and they started eating a high-protein, high-fat Western diet, right? Didn't they do that? We all agree on that? I mean, if anybody has a problem, we need to stop. Because you can look around the whole world, and you see people who live on starch-based diets, diets based on rice, corn, potatoes, with the addition of fruits and vegetables, and very little meat, very little oil. These are trim, healthy, hardy people who avoid the chronic diseases that are plaguing people in this country, that result in 3/4 of the healthcare dollars being spent. When these people from Africa, the Middle East, and the Far East, they move to the United States or Western Europe, they lose their immunity to obesity and sickness. Why? Because they change their diet. Okay. Now let's just take this one step further. What if we took this fat family over here and we bought them a one-way ticket to Japan? And we told them that they had to go live in a village, a farming village, and they had to eat the diet the villagers ate, and they had to work in the fields. What do you think would happen? Does anybody have any doubt what would happen? Of course not. They would be cured of their sicknesses and obesity, of course. All right, I want to just talk to you about a general concept here. I told you acute illnesses, we do really well. We should be proud as doctors to take care of acute care problems. I know I generally sound very condescending about the medical business and about some of my colleagues. I mean to. But it's not fair to generalize, because there are some exceptions for sure. And one of the exceptions we should be very proud of is what we do with acute care problems. Well, there's a reason we do well with acute care problems, and that's because of the nature of acute care problems. Acute care problems are due to single injuries to the body, like that bacteria that attacks the body. And we intervene with that antibiotic, and we disrupt the process. We tip the balance in favor of the patients, and everybody's thrilled. I mean, the patient loves the doctor loves his or herself because they did a good job. They helped their patient. Another acute injury, single injury, would be breaking a bone. Okay? We go in, we straighten that bone out, everybody's thrilled. Or you get a laceration. Again, you go in, you sew up the wound, the patient is so thrilled because you are such a great doctor. Now, what all of these problems have in common is they're due to single injuries to the body. Yeah? There's the difference. Is chronic disease is due to repeated injuries to the body. Say I had a nervous habit and I scratched myself every day for 10 minutes and I developed a sore on my hand. I could put the most expensive antibiotic cream that Upjohn Company makes on that sore, and I'd continue to have a sore until I did what? Stop the repeated injury, right? I used to have a terrible disease back about 35 years ago. I used to cough and wheeze, and I couldn't walk up hills. I was very sick. And the reason I was sick is because I repeatedly injured myself 40 times a day with Marlboro cigarettes. And within a week of quitting, I no longer coughed and wheezed, and I can run up hills today that I couldn't walk up when I was 25 years old. You see, I identified the source of repeated injury, and I stopped that behavior. That's what lifestyle medicine is about. It's identifying the source of repeated injury, which is easy. I mean, that's really easy. We'll go on to that in just a second. And we stop that behavior. That's the hard part, and we'll talk about that as this weekend goes on. I mean, that's really what our skill, our art is about, is helping people make these changes and stop this behavior. So what is the source of repeated injury for people in our society? What is causing all this disease? What's causing the disease is this, is 4 and more feasts a day. Every day, for every American, they start out with Easter for breakfast, they go on to Christmas and Thanksgiving for lunch and dinner, and every night after dinner they have a birthday party. That's it, period. What we have to do is we have to get our patients to feast on occasion, not every day. Not 3 times a day, 4 times a day, 7 days a week. That's why they're sick. Okay. Now, a little more agreement if we could here. The Surgeon General of the United States has come to a similar conclusion. The Surgeon General has told us that our diseases are due to our diet and lifestyle. Has told us that 5 of the 10 leading causes of disease, these would be cancer, strokes, heart attacks, and other forms of atherosclerosis, are due to our diet. And then the Surgeon General went on and said 3 or 4 of the other are due to alcohol. This is our forte. This is lifestyle medicine, is to correct these. This is the cause. This is the only thing that will work. All right, so let's talk about some basic principles of medicine. You're a doctor. Patient walks into your office with a chronic cough, with wheezing and very sick. What is your response? Do you put them on smoker's vitamins? Is your initial response cough syrups, antibiotics? No. What your primary effort is, and everybody would agree, any good doctor would do this, right? Get the patient to quit. I mean, this is obvious. Okay? The drunk walks in your office. What do? What is your effort? Diuretics, extra vitamins. Your goal is simple, is to stop that behavior, isn't it? Okay. Now, this guy walks into your office. What is the treatment? I'm talking about the treatment that is administered by 99.99999% of the doctors in this country. That's the treatment, to fill their medicine cabinet full of drugs. That's bad medicine. Okay, I just read a book. I love this book. It is by Khalid Hosseini. Did anybody read The Kite Runner? Put it on your list. It's a wonderful book. He makes a statement of this. He says, now, no matter what the mullah teaches, there is only one sin, only one, and that is theft. Every other sin is a variation of theft. Do you understand? When you kill a man, you steal a life, Baba said. You steal his wife's right to a husband. You rob his children of a father. When you tell a lie, you steal someone's right to the truth. When you cheat, you steal the right to fairness. Do you see? When you misrepresent the benefits and risks of medication, surgery, or other popular treatments, then you steal a patient's right to health and happiness and their money. When you fail to inform someone about the importance of lifestyle medicine, then you steal that person's right to live free from sickness and medication. So lifestyle medicine is the standard of care for diseases of diet and lifestyle, and no one should take any lesser stand. If you do, you fail yourself and your patients and society. That is the truth. Doctors should be criticized and penalized for using drugs and surgery when a change in diet and lifestyle would achieve similar or even better medical outcomes. That would be one way of stopping this practice, wouldn't it? Well, what about people who are unwilling and unable to change? What do you do then? Yeah, that's a good question. Now remember, we're talking about diet and lifestyle problems, and I want you to be very clear about this. There are some wonderful things about medicine. I don't want you to deprive me of these advantages. If I ever get in an accident and I end up in the intensive care unit, don't you walk in with a bowl of mashed potatoes and a carrot and say, that's your treatment, buddy. We're talking about diet and lifestyle diseases. What do you do with these people who won't change? Well, you know, carefully use medication and try and ask the question, am I doing more harm than good? And you've got to ask it very carefully. And look at the patient and see whether there is a difference, a real difference, not just risk factors. But you know, people love drugs, don't they? They just love medication. So I got another idea for you. I know you're not supposed to be market and profiteering here, but I got to do this anyways. Mary and I developed a new pill. And because you're all colleagues, I'm going to tell you all about this pill. It's embossed with an M on it, which stands for McDougall and sometimes money. And this pill sells for $2.45 a piece, and you have to take 2 a day until our mortgage is paid off. Now, I'm going to share with you the secret ingredients, okay? There's 1/2 gram of dried powdered banana, 2 flakes of Quaker oats, 1 broccoli flowerette, 1/4 of a kidney bean, and 1/2 of a small dried potato eye in this pill. Now, you know, some people, they want the really good stuff. And so we have a super duper special pill. They're $12.95 each, again, 2 a day, and to make those pills, we put in 3 sesame seeds. But of course, the caveat is this, is that these pills don't work unless you change your diet and you exercise and you clean up your bad habits. But don't you think I'd be much more popular if I did this? To say nothing about the yacht I'd own. Thank you very much.